Hello, my name is Maya Sarkar, and today I will present my work on interpretable language models for closed-loop type 1 diabetes control. In this research, I show that if an LLM is trained on the insulin dosing decisions of an expert teacher reinforcement learning agent, it can achieve similar blood glucose control while providing human-readable rationales, transforming the insulin pump from an opaque black box into a trustworthy co-pilot. Living with type 1 diabetes means constantly doing hard mental math, counting carbs, estimating insulin, and thinking ahead about things like exercise, stress, and timing. An artificial pancreas system helps lift that daily burden, making diabetes much easier to manage and autonomous, like a self-driving car, and improving quality of life. The aim of my controller is to ensure glucose is in a safe range, around 70 to 180 milligrams a deciliter. However, giving too much insulin leads to hypoglycemia, which is dangerous in the short term. So the controller has to be effective, but also has to be very safe to use. Artificial pancreas systems have evolved from classical PID and MPC controllers to methods utilizing reinforcement learning. RL can perform well and can work without meal announcements, but it is hard to interpret. Our approach, LLM-T1D, maintains the strength of RL while adding trustworthy language-based explanations and safety checks. The key problem with a purely RL-based controller is that it gives a number, like 1.5 units of insulin, but it does not explain why it gives that number. That creates a trust gap for a patient or clinician. In a medical system, especially when controlling insulin, a decision without an understandable explanation is not enough. LLM-T1D is built on three main pillars. The first is mathematical expertise from reinforcement learning. The second is semantic distillation into a language model. Thirdly, there is a deterministic safety, so the language model never directly controls the pump without implementing guardrails. We are modeling glucose control as a partially observable problem because the controller only sees delayed and noisy sensor data. It does not directly know a person's true internal metabolic state. To make the RL agent safer, the agent receives a very large negative penalty when glucose becomes dangerously low. This teaches the system to prioritize survival over aggressive optimization. This slide shows the reward function more clearly. If projected glucose falls below a severe hypoglycemia threshold, the agent receives a catastrophic penalty, as I mentioned earlier. Simply put, the controller learns that avoiding dangerous lows is much more important than trying to perfectly control glucose. A key challenge is that LLMs do not perform well with raw numerical arrays, so we use a textualization engine. It converts raw glucose history and insulin information into structured text, containing current glucose level, trend, and insulin on board. This gives the LLM a clear clinical context instead of raw numbers. Afterwards, we implement knowledge distillation. The RL agent acts as the teacher and generates expert-level state action trajectories. The LLM acts as the student and learns to imitate those decisions through LoRa fine-tuning. The end result is a model that can recommend an action and furthermore explain it in natural speech. Here we see why this matters. For example, if glucose is high and rising, the model may recommend a correction bolus and explain why. If glucose is falling fast and active insulin is still present, it chooses to recommend no additional insulin and explains that it is doing so to avoid insulin stacking. This makes the decision easier to understand. The explanation alone does not ensure complete safety. A language model can still hallucinate. If an LLM directly controlled a pump and made one wrong recommendation, the result could be highly dangerous to the patient. Because of this, the reasoning engine must be separated from the hardware execution engine. This slide shows the deterministic safety override layer. Every LLM recommended dose is checked by hard-coded safety rules. These rules consider insulin onboard limits and glucose rate of change. If the proposed dose is deemed unsafe, the system overrides it and uses a safer fallback. In the UVA Padova simulator, we evaluated adults and adolescents with unannounced carbohydrates. LLM-T1D achieved 73.50% adult time in range, better than the 69.12% for the RL expert. It also reduced the RL failure rate from 2.79% to 1.60%. So the LLM student improves both performance and stability when compared to its RL teacher. This table gives a broader comparison. Llama 3.18b gives the best adult time in range, while also reducing failures compared with PPO. For adolescents, the LLM also reduces failure rates compared with the RL expert. The clinical baseline still has very low failure, but it depends on meal information that requires continuous input from the patient, while the LLM controller works autonomously. One interesting result is that distillation acts like a mathematical smoother. Raw RL policies can have sharp, unstable action spikes. When the policy is translated into semantic token space, the LLM filters out some of those extreme reactions. In result, there's a smoother and safer insulin trajectory. For deployment, we separate the control and explanation paths. The control path should run locally on pump hardware, with a compressed model and deterministic parsing. The explanation path can run asynchronously on a mobile edge device. This keeps dosing real-time and reliable, while also preserving battery life. Let me show you the simulation.
Standard microdosing basal rate. Glucose is recovering to optimal fasting levels. I detect a sudden, sharp upward trend. The rate of appearance of glucose from the gut indicates a fast-absorbing unannounced meal, delivering a proactive 1.8 U bolus to intercept the spike. Glucose is surging rapidly. The initial bolus is still diffusing into the capillaries, delivering an additional 0.5 U to increase the concentration gradient and speed up absorption. Glucose is high but the velocity is slowing. You have 2.1 U of active insulin binding to cellular receptors, delivering 0.0 U to avoid insulin stacking and a subsequent delayed crash. Glucose is peaking just below the 180 mg per deciliter limit. The active insulin is sufficient to handle the remaining carbohydrate absorption from the gastrointestinal tract. Glucose is safely trending downward. Muscle and adipose tissues are actively taking up glucose. No action required. Downward trend continues steadily. The meal has fully digested, but 1.3 U of insulin remains active. Basal temporarily paused to prevent dropping below 100 mg per deciliter. Descent is slowing as the active insulin decays, resuming standard basal to execute a soft landing in the optimal range. Glucose stabilized post-breakfast. Violent upward trend detected. The sustained trajectory implies a massive carbohydrate influx, delivering a heavy 3.5 U initial bolus to saturate insulin receptors early. The rise is severe. Assuming a mixed macronutrient meal, gastric emptying will be delayed but sustained, adding a 1.5 U correction to combat the extended absorption phase. Hyperglycemia reached 195 mg per deciliter. I proposed a 2.0 U correction, but the safety layer rigidly capped it at 0.5 U due to a massive 4.8 U already in the subcutaneous tissue. Severe hyperglycemia. However, delivering more insulin now will not clear blood glucose faster, it will only pool in the tissue and cause severe delayed hypoglycemia, delivering 0.0 U. Glucose has plateaued at 235 mg per deciliter. The predictive model forecasts that the massive 4.6 U of active insulin is finally reaching peak plasma concentration and will begin pulling this down shortly. Glucose is now falling rapidly. The large boluses have taken effect and cellular glucose uptake is maximized. No further action needed. Glucose has re-entered the target range, but the downward momentum is strong due to the heavy insulin tail, suspending basal completely to cushion the descent. Rapid drop continues. Liver glycogen breakdown is being suppressed by the high active insulin. Basal remains suspended to allow endogenous glucose to stabilize the drop. Descent is slowing significantly. The carbohydrate absorption from the heavy lunch is still trickling in, perfectly offsetting the remaining insulin. Glucose stabilizing, resuming standard basal to maintain equilibrium.
To conclude, LLM-T1D combines expert RL control, semantic reasoning, and deterministic guardrails. The main takeaway is that we do not have to choose between strong AI performance and human interpretability. A mix of the two is possible. With the right architecture, a black box controller can become a transparent and verifiable clinical copilot. Thank you.